um, joint call being hosted by the Women and Global Health Interest Groups here in the DC CFAR. And we're really fortunate. Our topic today is updates from IAS. And we're very happy that Dr. Lynn Moffinson has agreed to give us an update. And she had to truncate all of the amazing information she has to fit within this 30-minute time slot. So she will get us started, and then Dr. Natella Rachmanani will give us an update on long-acting ART, and Dr. Pullerwitz will give us an update from Pop Council on cognitive behavioral therapy as an intervention on stigma, psychosocial well-being in Nigeria. So Dr. Moffinson will get us started. She's a pediatric infectious disease specialist, well known to everybody who I'm sure is on this call. She's worked in the domestic and international arenas on research and clinical trials. Previously was at NICHD for 26 years, and she's now a senior HIV technical advisor at EGPAF, and also works as a consultant with WHO, UNAIDS, UNICEF, and is really a tremendous honor to have you, Lynn, to share your slides with us and your thoughts today.
Thanks. It's not letting me share yet. Let's see. Is that working?
Yep, we see it. It's not yet in presentation mode.
Okay, let me just, okay. Okay, well, thank you very much for asking me to join. My video, for some reason, isn't working, so you can't see me. I apologize. And this is just part of a larger slide set that I just sent to Vivian that she can send out to everyone afterwards. So I'm going to start by talking about slides and abstracts related to perinatal transmission and the prevention cascade. And the first slide comes from South Africa, and it looked at factors associated with breast milk transmission. It was a retrospective study of over 50,000 infants in the Western Cape that were born between May 2018 and August 2021, so a 3-year cohort. Most of the mothers were receiving treatment. 51% started prior to conception, 27% during pregnancy, primarily NNRTI-based therapy, and at delivery, 78% of the mothers had a viral load less than 1,000. So the overall mother-to-child transmission rate was 1.8%, 0.9% in utero, 0.4% intrapartum, and 1.5% through breastfeeding. And these are kids who were diagnosed at over 3 months of age. So they then evaluated risk factors for breastfeeding transmission in mothers with known HIV positive status at delivery and infant diagnosed at age greater than 3 months. So younger age was associated with breastfeeding transmission with a 1.5-fold increased risk if 20 to less than 30, 2.2-fold increased risk if less than 20 versus greater than 30, and higher parity. Additionally, inconsistent treatment during pregnancy increased risk, and you can see up here in the timing of ART, before pregnancy and during pregnancy without gaps, no problem. But once you start having gaps, or if you're receiving no treatment, there was an increased risk, low CD4 count, no surprise, and higher viral load. The next abstract was a microsimulation model to estimate the impact of viral load testing and mentor mothers on transmission in a high HIV prevalence setting. So they described a hypothetical cohort of women with recent HIV starting treatment during pregnancy and continued throughout pregnancy and breastfeeding, and looked at the risk of mother-to-child transmission. So their assumptions for no viral load testing and no mentor mothers was that the women were starting dolutegravir treatment at 5 months gestation, so about 20 weeks. A risk of viral failure, 9%, risk of loss to follow-up, 25%, coming from observational studies. They assumed two types of viral load testing, 50% adherence or 100% adherence to viral load testing, assuming viral load was done 3 months after starting treatment, and then every 6 months during breastfeeding, which was Kenya's recommendations. They assumed 50% resuppress with counseling and no switch to second line if repeat viral load was unsuppressed. And then with the Mentor Mother program, based on, again, observational data, they made the assumption loss to follow-up would decrease from 25 to 10%. So they then evaluated 6 strategies, including combination Mentor Mother and viral load testing, the 6 strategies shown here. So NT is no testing. Viral load testing 50%, viral load testing 100%. There was a 0.5, 0.1% to 0.5% relative reduction in transmission, so a relatively limited impact of viral load testing. Mentor mothers had a greater impact with an 11.7% reduction, and concurrent implementation of both had the greatest impact. So why the relatively limited impact of viral load testing? Well, viral load testing can only improve outcomes for mothers who are retained in care and have unsuppressed viral load. And only a small proportion of the women, 9%, had unsuppressed viral load. So if viral failure was higher, the impact would be probably higher. Why the greater impact of mentor mothers? Well, mentor mothers intervened further upstream in the cascade of care, preventing loss to follow-up, and therefore had the potential to impact a larger proportion of mothers than viral testing alone. So the greatest impact was with combination testing and mentor mothers and viral load testing. They didn't account for the potential to use enhanced infant prophylaxis if the mother was viremic. But since only 9% were viremic, this probably wouldn't have made much of a difference. This is a Know Your Child Status study. USAID in 2022 rolled this out to 173 project-supported sites. And the Know Your Child Status attains line listing of all women with HIV on treatment from each facility and polls biologic and non-biologic children contacts. The project then provided resources, including registers, test kits, transports, to facilitate HIV testing. So 85%, or a little over 30,000 women with HIV accepted line listing, of which they elicited 56,521 contacts, or an average of 1.8 child per woman. Of these contacts, only 43%, the blue here, had a known HIV status. That left over 28,000 contacts with unknown status who were tested. They identified 903 children with HIV who were less than 19 for a yield of about 1.5%. All of the children identified were linked to treatment. And interestingly enough, the median age of the children who were identified with HIV was 15.2 years, and female contacts were more likely to test positive than males. So Know Your Child Status required a large volume of HIV testing to find the positive patients, but was a crucial and successful strategy to ensure that no child or adolescent was left behind. The next abstract comes from the IDEA Consortium in Africa. And as vertical transmission declines with maternal treatment, the predictive value of a single infant positive PCR decreases, and the probability of a false positive result increases. And therefore, all positive tests should have confirmatory testing to avoid misdiagnosis and unnecessary treatment with ART. So what they did was evaluate the prevalence of unconfirmed testing in African IDEA infants born between 2004 and 2011. And an unconfirmed positive was defined as an infant with only one positive test at age less than 18 months and no additional testing done at age less than or greater than 18 months. So there were almost 73,000 perinatally exposed infants, of whom 5%, had one or more positive tests. Of these children, of the 3,652 children, 44% lacked a confirmatory test at less than 18 months, and most of these never had a repeat test. This looks by Africa region, and you can see that the rate of unconfirmed test varied significantly by region, with it being most common in West Africa, followed by Central and East Africa, and uncommon in South Africa. And having an unconfirmed test without any test after 18 months was similarly frequent in all arms. Happily, this unconfirmed prevalence decreased over time. So an unconfirmed positive test was highly prevalent, but less common in more recent years, and additional efforts are needed to ensure that confirmatory testing is done to reduce false positive results, particularly as we move into a universal ART era. This is an update on the Tasambo study in Botswana, which is the surface birth outcomes surveillance study at sentinel sites, covers 70% of births in the country. And overall, between 2014 and 2022, almost 240,000 deliveries occurred in these sites with the valuable infant surface examination. So they've moved from 2018, where there were only 432 women with dolutegravir from conception, to now well over 11,000 women with dolutegravir from conception. So the prevalence of major defects was 0.62%. And the chart here shows you dolutegravir at conception, non-dolutegravir at conception, dolutegravir started during pregnancy, non-dolutegravir during pregnancy, and HIV uninfected. And you can see that there was no significant prevalence difference by exposure. There were 162 neural tube defects, which was what, of course, we were worried about, with an overall prevalence of 0.7%. And you can see from the graph here that there is no longer any significant difference in neural tube defect by exposure category. Neural tube prevalence was higher when conception was in May and June than August through October, and differed by calendar year. So you need to follow this over time. This is a study from Eswatini that EGPATH has done with VIV funding, and it's birth defect surveillance that's very similar to the Botswana Tasambo study. And these are data from September 2021 to March 2023. And this was conducted at the 5 highest volume maternity sites in all 4 regions of Eswatini, covering 73% of all births in the country. There were almost 36,000 pregnant women, of whom 30% were HIV positive. 88%, actually 89% of the HIV positive women were receiving dolutegravir treatment. So dolutegravir has really been integrated into antenatal care in Eswatini. The vast majority of these dolutegravir were pre-conception, and you can see here the other timing of start. And this looks at birth outcomes by HIV and ART status. So if we first compare HIV negative and HIV positive, you can see there's no significant difference in major birth defect prevalence by HIV status. If we look specifically at neural tube defects were slightly higher, non-significantly, in HIV positive than HIV negative, 0.11 versus 0.08. Now, comparing to HIV positive to HIV uninfected, HIV positive women, all of whom were on treatment, still had an increased rate of stillbirth, low birth weight, and preterm delivery despite treatment. And then if we specifically look at HIV positive women, we can see there's no significant difference in any of these parameters between women receiving dolutegravir versus non-dolutegravir at conception, either defects, stillbirth, low birth weight, or preterm delivery. Neural tube defects was slightly higher in non-dolutegravir compared to dolutegravir at conception. So most HIV positive women in Eswatini are receiving dolutegravir, but despite treatment, HIV positive women had slightly higher adverse pregnancy outcomes, which has been seen in other studies, but no evidence that this is increased with dolutegravir versus non-dolutegravir. Moving on to PrEP. This is a study from Kenya that looked at factors associated with PrEP. So they looked at women who would accept PrEP versus HIV self-testing or combined HIV self-testing with PrEP using data from a PrEP implementation study called PRIMA. There were 911 high-risk women who were offered HIV self-testing for the male partner with unknown status and also offered PrEP. So you can see that HIV self-testing was actually generally more acceptable than PrEP, 55% accepting HIV self-testing, 4% PrEP alone, 14% both together. Offering self-testing increased the male partner's HIV status awareness from 5% to 82% and increased couples testing from 18 to 76%. So it was very useful. Reasons for accepting or declining HIV self-testing or PrEP. Declining need to consult partner was the primary reason. Accepting PrEP at enrollment was associated with not knowing their partner's status, and declining PrEP at enrollment was associated with the woman having a low view that she would be at HIV risk. There were a number of covariates that were associated with the different interventions. For example, being married, a history of IPP, suspicion that male partner has other sexual partners was associated with taking both PrEP and HIV self-testing. And you can see the other factors here. So awareness of the male partner HIV status guides the woman's HIV prevention decisions, and low HIV risk perception may hinder acceptance of HIV self-testing and PrEP. And women were unable or unwilling to negotiate who were unable or unwilling to negotiate HIV self-testing preferred receiving PrEP alone. This study looked at the potential acceptability of offering differentiated community-based PrEP delivery in 394 pregnant or postpartum women enrolled in ongoing studies in South Africa and Kenya. So this shows you the participant characteristics. The median age was 28. Yes, most of the women were postpartum with some differences between South Africa and Kenya. Greater than 50% had experience with using injectable conception or other contraception. Most had some secondary school, most were not employed, and there was a difference between cohorts in a large number of these variables. So when asked, would you be interested in accessing your HIV prevention product through community delivery as opposed to a clinic or a hospital, 59% said no, 41% said yes, but you can see that there were significant differences between the countries with much more interest in community delivery in South Africa than in Kenya. Predictors of community PrEP delivery preference was younger age, internalized PrEP stigma, and disliking oral PrEP side effects. Negative predictors of community was being in the Kenya site and having one or more current sexual partners. So this study showed the importance of offering a choice of community versus clinic options for PrEP pickup and the need for context-specific strategies as they varied between countries. This is, again, looking at Kenya, and they were going to evaluate the use of injection PrEP. So in Kenya, they use private pharmacies for differentiated PrEP delivery. And they have an ongoing pilot study. And they surveyed 496 PrEP clients regarding the preference for either oral PrEP, injectable PrEP, or the vaginal ring if women. About 50% of the PrEP clients were women and less than 25 years, 85% PrEP naive. So if in looking at all respondents, 65% said that they would prefer injection, 35% said they would prefer an oral pill. And when they did a subgroup analysis, females greater than 25 years were significantly more likely to prefer injectable over oral. Factors associated with preferring injectable were age and the site. And then for women, looking at oral PrEP versus injectable PrEP versus dapivirine ring, 58% ranked injectable PrEP first, 30% ranked the oral pill first, but only 2 listed the dapivirine ring as first choice. So most, but not all, clients indicated a preference for injectable PrEP. This varied among subgroups, and again indicates the importance of offering a choice, both oral PrEP as well as injectable PrEP. This study is the LIFT study from the HPTN. It's a single-arm study in 55 adolescent girls, 18 years or younger, in 3 countries. And they were initially initiated on oral CAB, then moved to IM CAB, and at step 3, at 48 weeks, they were offered the choice between continuing CAB, IM, or tenofovir FTC orally. And 48 weeks, 92% chose to continue injection cabotegravir. They did qualitative in-depth interviews with patients and parents, and you can see emergent themes that were facilitators and emergent themes that were barriers to the use of injection PrEP. So CAB-LA was highly acceptable to adolescent girls and young women, with 92% choosing to stay on CAB-LA, and most felt the benefits outweighed the pain of the injection. But again, choice matters. Some patients still preferred receiving oral tablets for a variety of reasons, and they recommend discussing potential barriers and facilitators with clients as part of decision-making. This is data from the HPTN open label extension, HPTN 084, and they assessed during the open label period PrEP choice. They could either continue CAB-LA or get oral PrEP, the reasons for choice and factors associated with the choice. So this included almost 2,500 patients in the open label period. 78% chose to receive CAB-LA, but this varied by arm. If they were in the CAB-LA arm, they were more likely to get CAB. So the blue shows you CAB without an oral lead-in, the green shows you CAB with an oral lead-in, and oral is in yellow. People randomized initially to the oral arm, 52% decided they wanted to receive injection CAB, while 33% decided they wanted to stay on tenofovir. Product choice varied significantly between countries, with injection CAB preferred by 92% in Botswana compared to 69% in Uganda. Those who chose CAB appeared at increased risk for HIV and more likely not to live with their partner, have had experienced recent IPV, and to have been paid for sex. Interestingly, if the women were pregnant, they were actually a little bit less likely to choose injection CAB compared to continuing with oral. Reasons for product choice is shown here, and really for injection, they preferred injections and didn't like pills, and for oral, they preferred pills and didn't like injection. No surprise here. So most chose injection CAB, only 15% with oral lead-in. Product choice were influenced by personal preference for product attributes, risk behavior, social geographic context. And again, at the expense of repeating myself, it shows the importance of having a choice of products available for women. This is a study that used the CPAC economic model to evaluate the cost effectiveness of oral tenofovir versus injectable CAB-LA in adolescent girls, young women 15 to 30 years in South Africa over 10 years. And they evaluated the highest annual drug price, the maximum price premium, where CAB-LA has an incremental cost effectiveness ratio, or ICER, of less than $3,500, which is 50% of South Africa's per capita annual GDP and viewed as cost effective. And here were their input parameters for the model. Mean age was 26 years. Based on studies, this was the HIV incidence as shown here. Retention, again, based on studies. And they were assuming a cost of PrEP of $40 and CAB-LA of $80, and then they varied this. So this shows you the ICER. So comparing tenofovir FTC and CAB-LA, there were fewer incident infections and incremental life years, but the ICER was $3,440 if the CAB-LA price was $40. And this kind of shows you graphically, this shows you the annual cost of tenofovir versus the annual cost of CAB-LA. And in blue, it's cost savings. In light blue, it is the ICER that is acceptable. In the light yellow, ICER that's not. And in yellow, not cost effective. And our base case here, where CAB-LA was $40, was just at the level of being cost effective. So for CAB-LA to be cost effective in South Africa, it needed to be priced at no more than twice that of oral PrEP. So $80 versus $40. This final one on PrEP is on the dapivirine ring, and it is a study in Zimbabwe where adolescent girls and young women were offered either the ring or oral PrEP and followed up monthly. So the acceptance of the dapivirine ring by high-risk adolescent girls was pretty high, 76% accepted, higher in rural than urban areas. Self-insertion of the ring as opposed to provider insertion of the ring increased over time. And interestingly enough, PrEP continuation rates with the dapivirine ring shown in yellow were much higher than continuation rates with oral PrEP, which is in blue. The HIV incidence was not significantly different between the ring and oral PrEP, and most of the seroconversions in people receiving the ring occurred in the first month of ring use. And after the first month, it was mostly associated with women removing the ring and having unprotected sex. So this study showed a high acceptability of the dapivirine ring as opposed to the study we discussed before, higher continuation rates than oral PrEP. So that is reassuring and interesting. So I'm going to end with talking about pediatric and adolescent HIV treatment very briefly. And this is the CHAPPIS-4 study looking at second-line treatment options. So this is 919 children, 3 to 15 years, failing first-line treatment. They were randomized first to receive either TAF and FTC, or abacavir 3TC or zidovudine 3TC, depending on first line. And then they were randomized to the anchor drug of dolutegravir, darunavir, atazanavir, or lopinavir. This shows you the characteristics of the patients. Looking at virologic response, comparing the NRTI backbone, it was 89% with TAF, 83% with the other regimens. And with the anchor drug, we see that dolutegravir had the highest viral suppression, 92%, followed by darunavir, 88%. And this just shows you the percent difference. So TAF was superior to abacavir or zidovudine, dolutegravir superior to lopinavir or atazanavir, a trend towards darunavir being superior to the other two PIs, and atazanavir and lopinavir looked similar. So there was no difference in CD4 response, no difference in AEs. Most of the AEs were for atazanavir and bilirubin related. Dolutegravir had the fewest AEs than all of them, and there was a greater increase in total body weight with TAF compared to the others, and increase in total cholesterol and LDL with lopinavir ritonavir. Then they looked at weight changes. So first looking at TAF versus abacavir 3TC, you can see TAF in red had greater increase in weight and BMI for age. Comparing the anchor drugs, they were very similar in weight gain, with the exception that lopinavir ritonavir kids actually lost weight. And then they looked whether there was any interaction between dolutegravir and TAF, and you can see that in patients receiving dolutegravir, there was no difference in weight gain between TAF and the others. So TAF was superior to abacavir or zidovudine, dolutegravir superior to PI-ART, atazanavir was as good as lopinavir, which wasn't that great. Darunavir, ritonavir appeared superior to the other PI regimens, and lopinavir, ritonavir had lots of problems with being the poorest weight gain and least favorable lipid profiles, suggesting the need for child-friendly formulations of TAF and dolutegravir, darunavir, or atazanavir for second-line treatment. And I think in order to save time, I'm going to not go through the other few slides that I had and let you move to the others, and people can take a look at the slides that you'll send them. There's a much larger set of 80 or some slides. Thanks.
Lynn, thank you so much. So much information, and we will definitely pour over the remainder of the slides, and if people could please hold on to your questions till the other two presentations. Thank you. So the next presenter is going to be Dr. Natella Rachmanani, who's joining us from Children's National. Dr. Rachmanani.
Hi, everyone. I'm Natella Rachmanina. I work at Children's National and also a senior technical advisor at the ECPAF together with Lynn. I will just briefly cover the plenary that I have done on the long-acting treatment in adolescents. So this is not a specific study. That's a compound kind of outlook of where we are moving with adolescents with treatment options. Next slide. And obviously, the focus of my presentation, this is abbreviated version, would be on cabotegravir rilpivirine, which are already approved in clinical practice in resource-rich settings, and moving forward to being approved in and being procured for through generic manufacturers in resource-limited settings. So this process is quite more complex compared to us. So just starting by overview of the adolescents, do they really want the long-acting options? Is it going to work for them? Well, this is a single US-based study that has been published across 3 jurisdictions with high prevalence of HIV, asking young people about their interest to the virtual potential injectable ART. And you can see here the interested in the dark red bars, quite high proportion across all 3 sides. So overall, we are seeing high levels of interest, all in the range close to 90%, and in Memphis, slightly low, but it was also related possibly to the study design and desirability and some bias in the survey. It was quite slightly different RB approval. If you look, though, at the frequency of the administrations, if they were to ask to, the real difference is between weekly and monthly. Once you move to monthly versus twice every 2 months or 3 months, no huge difference. They kind of fall in the same category of the high blue bars. And finally, very interesting element, which we're seeing quite a bit, is who would want to have these injections based on the viral suppression rate. And you can see that definitely wood was the highest category in those with a highly detectable viral load, pointing out that this use who faces challenges with oral ART are most interested in injectable version. Next slide, please. Well, let's compare what they use in resource-limited settings are thinking about potential use of injectable ART. This is a really nice study published this year by Ilona Tasker, Lucy Kluber, and a group from Oxford in South Africa. They surveyed close to 1,000 adolescents, asking them about the preferences between pill injectable and other forms of long-acting ART. And very interesting that in this study, 1 in 8, only 12% preferred long-acting ART over single multiple pill regimens, so much stronger preference for oral regimens in the South African cohort. And you can see the factors that were associated with long-acting ART preference included medication stockouts, experiencing side effects, pill burden, past year treatment changes, and HIV stigma and recent ART initiation. And in a modeling, they estimated that 66% who experienced all these factors, so very complex use, would prefer long-acting ART. Next slide. And this is just a brief survey. I want you to take it with some grain of salt. This is a survey was presented in the paper, I think is about to publish, or has been published, if I missed, last couple of weeks, from MOCA trial, impact trial that looked at the long-acting ART in adolescents. And I say grain of salt because this survey was conducted at the stage where the adolescents continued on oral ART and received only one of the injectable agents in the first cohort, and then proceeded to cohort 2 with a full ART with dual drug regimens. And here they looked at the advantages and concerns regarding long-acting ART in this study. And you can see here the advantages were clearly not need to remember in taking pills, avoiding the stress of adolescents for caregivers to watch them and supervise them, and not worrying about hiding pills from peers for young people. However, concern was repeated among several participants is ability to maintain a routine injection schedule, which requires exact appearance for injections within 2 weeks time window. Next slide, please. And just to highlight to everybody that currently available options for ART include cabotegravir or rilpivirine. There is also a lenacapavir option, and the focus here is on cabotegravir or rilpivirine. And this really requires adolescents who are suppressed, who have been suppressed for over 6 months period, and some other criteria here on the slide, and particularly those who are able to commit and accept long-acting injections and coming in a specific time window. Next slide, please. And I highlighted your presentation that our data internally here, we're in process of publishing, very much resonates with this British data. Adolescents actually eligible with HIV for the long-acting ART agents like rilpivirine. And in this British cohort of 121 youth, they actually identified that 40% would not be eligible, based primarily on the resistance, HBV co-infection, and high BMI. And even among those who would be eligible, fairly high proportion, 26% would require a multidisciplinary team risk-benefit discussion because there are other complicating factors that might make them ineligible down the line. Next one, please. And in my presentation, and I won't go in details of it for sake of time, I have shared the experience of our site in DC being among the first clinical sites in the US to run out and roll out the injectable ART program, specifically among adolescents and youth. And I have spoken, and will not go in details, over how many implementation challenges we faced in resource-rich settings. I'm happy to share with you that even since July, our population of long-acting ART now I think exceeds 25 patients. And we did observe some clinical challenges as well, looking at some complex history, combining cabotegravir or rilpivirine with lenacapavir, having observed some intermittent viremia and observing serious adverse events. So beyond just logistics of rolling it out, it's also quite presented few challenges on the clinical end. Next one. And I shared the paper with the audience where we published, and this paper has been just recently highlighted at Resistance Workshop in South Africa, where we observed some cases of viremia in youth who started and transitioned on long-acting ART after years of being suppressed on oral ART, and mainly raising the issues what to do about this viremia. Should we really worry about it? How would it affect treatment trajectory? How would it affect laboratory monitoring trajectory? Next slide. And I'm finishing up by just really wanting to share with you the incredible quotes of the youth who have transitioned to HIV. These are direct verbal quotes from the young people, and talking about the experiences, why they decided to switch, and some really saying daily pill worked for me, but I was ready for something new. Talking about the experience with pain, talking about the experience with being viremic and it being challenging U equal U situation and approach that they use in the sexual and reproductive health. Next one. And just to finish up, definitely the conclusion is long-acting ART provides quite unique opportunity to optimize care and treatment for adolescents, but there are quite few unanswered questions that we need to work on. And this include acceptability, as you saw, a big difference between US-based and South African-based data. A lot of implementation experience in challenges, sustainability of this population, potential fatigue of injections, and mainly involving youth people in the design of the studies and rollout of the programmatic implementation is crucially important going forward. I stop here. To you, Julie.
Thank you very much, Dr. Rachmanina. And we'll move on to our last presenter, Dr. Julie Pillerwitz from Pop Council.
Thanks so much. Can everyone hear me okay?
Yes.
Terrific. And great to see you all here. I'm one of the co-chairs of the Global SIG. Really pleased that we're having this session and able to join with our colleagues. And I'm based at the Population Council and also an appointment at GW. And I will be quickly summarizing my presentation from the conference, from the IAS conference. Next slide, please. We come to this work, this is a project focused on stigma reduction and mental health promotion. We come to this work being aware that the effects of stigma are compounded when negative assumptions and stereotypes are internalized, which is also called self-stigma. And we know that internalized stigma is associated with a number of negative health outcomes, mental health, physical health. So we came to this research because there are actually very few evidence-based interventions that address internalized stigma for sexual and gender minorities, either at risk for or living with HIV. And as far as we're aware, there were none in Africa. So that led us to develop a novel intervention to try to address stigma and mental health for sexual and gender minorities in Nigeria. And this building on longstanding work of the Population Council in country, and that there's a longstanding office and with funding from the Elton John AIDS Foundation. Next slide, please. So we were able to do a small RCT with about 250 men who have sex with men and transgender women in Lagos, Nigeria. And in addition, we had qualitative research with participants, program staff, and program facilitators, and looked at a range of outcomes: stigma, resiliency, depression, etc. Next slide, please. I thought I'd spend a minute or two just on what this intervention is. So it's a novel intervention which is building on cognitive behavioral therapy. But instead of it being a one-on-one program, this is a group-based cognitive behavioral therapy, which is increasingly common now, to permit it to be an opportunity for kind of shared resiliency amongst the group, and it uses an affirmative framework. So in this case, affirming one's identity. And we adapted this curriculum from one for sexual gender minorities in Canada and combined it with several African-based anti-stigma curricula. We also wanted to be able to kind of widely roll this out. And so this program was facilitated by community-based health extension workers who were trained by psychologists, but it wasn't offered only by psychologists. I would also mention that this is an HIV status neutral intervention, so addressing both people who are living with HIV and those who are at risk of HIV. Ultimately, we had 4 sessions in the intervention that looked at processing stigma related to different identities, really addressing cognitive behavioral therapy methodologies, building kind of resiliency and coping skills for individuals and in a shared context, and developing supportive networks. Next slide, please. Here are just a couple of quotes from participants about their experience. The teachers did a wonderful job. I'm going to move my picture, it's covering the quotes. Did a wonderful job showing us how stigma can be fought, coping mechanisms, how you overcome fear, and how you stand firm for your rights. A second person said, I used to think so badly about myself, but after the workshop, I was like, yes, I'm still a somebody. And then lastly, the workshop opened my eyes. If I don't take care of myself, no one else will. Next slide. We saw from the RCT that there were significant improvements in a number of different psychosocial outcomes highlighted here. We also saw some improvements on the within the control communities or within the control groups, which I'm not going to go into detail here as to how that developed, but that did mean we were having difficulty showing the differences between the arms, but we saw significant positive change. Next slide, please. We also saw some indication of increased PrEP uptake, both quantitatively, and here you see a quote, before, now I didn't take PrEP because I saw it as a punishment, but after this study, we normally take it the way I'm supposed to, and two of my friends have taken it up because of the workshop. Next slide, please. So a couple implications from this project to date. We see that this is a promising approach, this affirmative group-based CBT approach. It was feasible, acceptable in the context of Nigeria, and we saw some indications of positive outcomes despite some of the challenges with the RCT. And we designed this with the intention of being able to have impact at scale so that you could do this in a group setting and with facilitation by community health workers. We didn't go with peer educators, for example, but community health workers intentionally with some additional training by psychologists. And so we have a highly adaptable model here. And so I'm pleased to report that we recently received funding underneath the DC CFAR umbrella. So thank you to everyone who's involved with DC CFAR to be able to adapt this and pilot it and test it in the DC context. So we're going to be working with our colleagues at Us Helping Us and Whitman Walker Institute to adapt this and for Black sexual minority men in the DC area. So thanks very much. And I think that's my last slide. This is a slide of all of the contributors, acknowledging them throughout Nigeria and our colleagues. So thank you very much.
Thank you. Thanks, Julie. That was very interesting and very happy to see that you'll be working on this in DC and look forward to that moving forward. So we'll open up for questions. And Lynn, lovely to see you. So I'm glad your camera worked.
I had to reinstall it.
Ah, I see. So any questions for Lynn, for Natella, Julie?
So,
Probably.
may I ask a question?
Yes, Benjamin, go ahead.
Hey, I'm Assistant Director of Microbiology Lab at Children's National. It is very exciting to listen to this presentation, especially the presentation from Natella suggesting the long-acting injectable drugs will be used, actually has been used in Children's National. So as a laboratorian, my question is, what are the opportunities for laboratorians or labs to work together with physicians to catch up with the pace of the clinical side in terms of laboratory testing, drug resistance, and kind of adherence checking?
Thank you, Benjamin. Natella or Lynn?
Yes, thank you for asking, Ben. Basically, I think we're still trying to answer the question of the significance of those viral blips that we have observed. And I think for us, from laboratory point of view in particular, archived resistance becomes really important. Most of this viremia is in the lower range. It is above 200. As you've seen, I didn't go in details. A couple of our patients had viremia as high as 800 and 1,000 copies. And those are young people who had absolutely undetectable viremia with maybe one or two minor viral blips in the past on oral therapy. And even those blips seem to be related to openly admitted some issues with adherence or insurance access. So what does it mean with injectable? Is it a behavior of the depot in young people? It might be different because in all the clinical approval studies, the median age was 35 years. So you question yourself whether there's some specificity about younger muscle tissue, so it's unknown. Unfortunately, we have tried to measure drug levels. So to answer your question is capacity to measure drug levels. For example, in this case, we were unable through reaching even to Johns Hopkins University and other to get and manufacture of the drug to measure the drug levels to see if there was any relationship both to the adverse events, which has been reported in clinical trials with rilpivirine and intravascular penetration potentially. So that would be real of value. And I think the capacity to early detect if any emergence resistance, if these blips carry any value clinically of any early emergent resistance, and this type of studies would be interesting. At the same time, potentially down the line and a relationship to long-acting ART and to Lynn's presentation on the long-acting CAB as a PrEP, which we also have rolled out. I think the capacity potentially for self-testing and the capacity to do HIV self-testing at home settings, that would be something that's in another direction you could take. It's not has taken yet in US. Studies are primarily carried overseas for this modality, but I think in this direction, laboratory input would be great, from my opinion as well. I don't know if Lynn wants to add anything.
No, I think you said it. I think, there's a lot of enthusiasm about moving forward with CAB for PrEP, but very limited data in adolescence and even less data in pregnancy. So, studies in pregnancy and in adolescence are really critical.
Thank you. Alan?
Thank you. Many thanks to our three amazing speakers. That was quite a powerhouse of information in a short period of time. One of the themes that ran through your talks was the translation of scientific findings from resource intensive settings to resource less intensive settings. And I'm curious about your impressions about it. That was always a dream and an aspiration, but it seems that there's some evidence that people are actually taking this seriously. And what's your impression about how this has evolved over time, about scientific community's ability to translate findings on one side of the ocean to others?
Which person are you asking, Alan?
Any of it. You all had relevant comments, so whoever wants to take it.
I'll give a quick start, which is moving from development of combination treatment in like the US and Europe to combination treatment in Africa took how long? Huge amount of time. Moving from combination treatment in pregnant women to combination treatment in pregnant women in resource limited settings, I would say maybe once we had treatment in the countries, maybe 10 years. But moving from oral PrEP to oral PrEP implementation has been far more quick. Not necessarily optimal, but moved relatively quickly into resource limited settings. And it will be interesting to see what happens with CAB LA. There are like 20 different implementation projects in different countries being planned for implementation of CAB LA. And that's only within a year or two following the study results. So my hope is that this shows that there is an improvement in our being able to move things from here to there. That's my general thought. Julie, Nutella.
Thanks, Lynn. I guess what I complement that with is that I see now that there are opportunities to bring some of the lessons we've been learning in low and middle income countries here to the US and here and to higher income countries. And so that's, I think, very exciting in terms of some of what we're learning from community-based programming, for example, or addressing some of the contextual issues around gender and stigma, for example, is something that I see quite often in international settings and low and middle income settings. And there's opportunities now that I see to bring those in the other direction. But coming back to Lynn's point, I think that there's increasing momentum, particularly under the umbrella of implementation science, to think about adapting for different cultural contexts and different settings for a number of the products and strategies that we know to be effective. So it's an exciting time. Thanks.
And I'll just finish up by saying that I think we're seeing stronger community engagement component across the border as we move from clinical trials to the implementation work. So I think we're hearing and more attuned to and are more faster in our ways of linking to the community perspectives, and also translating the trial findings in the community engagement into the implementation elements. So to me, it's been quite transformational in recent, I would say, probably 5 years from that angle, to complement Lynn and Julie.
Thank you.
Thank you. Dr. Downer?
Hi, this was so exciting. Thank you so much. Just the addition of the community as part of this, because we know oftentimes they're not part of this. I'm just curious though, we know that nutritional status modulates the immunologic response to HIV infection. And I'm wondering if that was included at all in the work that you're doing. But thank you so much. Food security in the areas that you're talking about is huge, is huge. So I'm just curious as if that was a component of what you included in your research. Thanks.
From the point of view of the abstracts that I reviewed, I didn't see anything that accounted for that in this particular meeting, but also I wasn't necessarily did a search for nutrition, so I can't say that it actually wasn't dealt with. It wasn't just what I reviewed.
Lynn, I wonder with the dolutegravir and pregnancy studies, to what extent that seasonality that you refer to may be a reflection of diet changes during different seasons. So I know it was something that early on was kind of piqued interest based on where these cases were popping up. So
yeah, it's a good point. It's a very good point. So Botswana does not have folate supplementation of their food. But it's still potentially possible that there were population differences in folate during the different time periods. When Rebecca presented the data, she gave a number of different hypotheses, but they don't really know why there was a difference. We in Eswatini, we did see differences in quarters in terms of reporting of birth defects, but we only had about 1.5 years worth of data, so we're not really able to address that very much. And Eswatini, like Botswana, doesn't have folate supplementation.
nice. Thank you, Dr.
May I bring it back to Dr. Donner close to home? I think, Dr. Donner, just to your comment, I want to echo what you said. I think food insecurity generally impacts in our local communities, just access to care. And when we're bringing something as long-acting, for example, in our clinic, this is a more important component because you cannot have an ongoing relationship with the frequent visits with somebody who has no food security. And an amazing proportion of our patients, I don't want to take more time, but we actually did a survey in DC, just few steps from where we're having DC CFAR house, that's still experiencing food insecurity. So just to say that for all the clinical implementation, I think no matter where you are in the world, food security should be addressed. It is addressed in our program, as I know, in SEBLIS program and many others through the Ryan White support or some other federal funding sources. So we're able to do this work, but it is definitely an extremely important element of capacity of the family to be engaged in care of the patient as well. And on the other hand, on the food-related issue, we have faced challenges, for example, for long-acting with obesity, which is frequently as a result of poor nutrition and poor nutritional education. And that represents, I think, a significant barrier in a lot of population in US. So potentially we'll have to look into this factor because high BMI has been associated with a failure of cabotegravir or Pibrin. Very brief comment, but definitely very important topic. Back to you, Seb.
Yeah. Thank you very much. And we're at 1:02. If our presenters have 3 minutes, I'd like to allow Dr. Kelvin and Dr. Tiem to ask their questions. But if anybody needs to sign off, thank you for attending today. Kelvin?
Yeah, so my question was on how we are addressing the HIV or the infections of HIV. I think also we should address the issues of climate change and also the pediatric access of ARVs.
Anyone want to talk about climate change as it relates to HIV? I think we did talk about ART for children and formulations.
I think those are all important issues. I don't know that
Yeah.
anything that I presented is directly relevant to that.
Certainly, I think any disruptions in service that we're seeing, and obviously in food security, any of those things related to climate are very important. Dr. Tiam, we'll end with your question.
Okay, thank you for the opportunity and thank you to the presenters. My question goes to Dr. Lin, the first question. And I know there is a practice in South Africa region that you have grandmothers helping to breastfeed children. If this happened and is still happening, does this have impact on the factors associated with breastfeeding transmission? And if not, I think it's a factor that needs to be considered. And my second question goes to Dr. Natella. I know we have fast acetylators and low acetylators, and like you mentioned, that you do monitor drug levels. Were this also considered in the case of those that opted for injectables?
Thank you, Dr. Tiam. Dr. Muffinson?
Yeah, so I have heard reports like that, but the factors that were looked at in the study that I reported from South Africa, that was not one of the factors that they listed. I think they chose women who were breastfeeding themselves as opposed to using a surrogate breastfeeding. So I can't really answer your question.
And Dr. Rachmanina?
Yes, thank you, Marva. Good question. In the cases of viremia that are reported, we immediately reached to manufacturer who declined to do the drug levels. I do know that, for example, in Canada, you can easily order cabotegravir piperine levels. I reached to the lab in Johns Hopkins University with whom I worked. They were not clear certified. They said they would run the drug levels, but would not relieve results to me. So unfortunately, in this case, we are left without. I do know there is movement forward to have TDM available, a therapeutic drug monitoring available for both cabotegravir and rilpivirine. And just to highlight your point, we know that with tenofovir drug measurements in hair as well, there've been some, and in urine, there've been some really good studies showing the validity of this as a evidence of the adherence. So I think for oral therapies and prophylaxis, we have used to look at TDM as a proof of adherence. For injectable, one proof of adherence is documented differently. I think that will arise more in the issue of relationship to virological response and depot behavior. And this is definitely currently a big area of the research, but not yet, to my knowledge, and wide acceptance in the clinical practice. And just to clarify the point I've made, in the clinical trials of cabotegravir rilpivirine, higher plasma levels of rilpivirine have been linked to this very rare serious adverse events, which we observed in the first 2 patients in our clinic, and they are believed to have produced by injection of rilpivirine into the bloodstream versus in the muscle. And this sharp rise on the concentration of rilpivirine in the plasma might be responsible for this systemic reaction, anaphylactoid-like reaction that we have seen that has been described. But this has not been published yet, so we are waiting for publication. It is included in the drug insert. So to summarize it, I think there is a place for drug level measurements. We just don't have yet a good clinical way of applying those, both for CAB-PrEP and for CAB-rilpivirine, but there's definitely interest in development in this field. Thank you.
Thank you very much, Dr. Rachmanina, Dr. Muffinson, and Dr. Pluritz. It's such a pleasure to have all of you. And Alan, I wonder if you want to give us any closing thoughts, since as the leader of our CFAR.
Well, just great appreciation to the SIG and the core and everyone for bringing these remarkable speakers together so we can all stay more current than we have time to do on ourselves, on our own, and we can learn from your expertise and combination of ideas. So thank you so much.
Thank you, everyone, and have a good rest of your day.
Thanks. Take care. It was a pleasure.
Thank you. Thank you all for
Thank you,
joining.
everyone. Take care.
Thank you,
you.
Vivian.
No, thank you.
Thank you.